Hello, my name is Yudivette Ortega, and today I will be discussing crisis management of two outpatient psychiatric scenarios. Um, I'll act as a psychiatric mental health nurse practitioner that's working in a busy outpatient setting. I'll be discussing safety, level of risk, and appropriate escalation of care, which are all key crisis responses that need to be done in situations like these. These cases highlight how I would approach my assessment and my decision making when patients present to me as a psychiatric mental health nurse practitioner. Patient one, in both of these cases, I should say, my role will be to evaluate the safety risk, figure out whether or not the patient can remain outpatient, or take appropriate steps to protect the patient or others. The first case that I'm going to talk about involves um, a patient who is experiencing a severe depressive crisis and reports suicidal intent. The second patient that I will be discussing involves a mom that is going through postpartum psychosis with a risk to an infant. In both situations, I think safety and stabilization are the first priorities before any therapeutic interventions occur. So, patient one is a 45-year-old male with a history of major depressive disorder and past pornography addiction. He recently experienced the sudden loss of his marriage in contact with he recently experienced the sudden loss of his marriage and contact with his children. This triggered a significant depressive episode. He started increasing alcohol use. His ability to function at work declined. And he also mentions having suicidal ideation with a plan. Um, and the plan is with a firearm. So when I hear these things, um, I have to determine a level of risk. Um, what places him at the highest suicide risk is a combination of a few things. He has active suicidal ideation. He has access to firearms. He has a plan. Um, and he doesn't have good support at home. His protective factors, such as his wife and his kids, are not there for him right now. And then also, I think the fact that he's unable to function at work and handle his job and daily functioning is also a risk. Um, and for me, this all of these things meet criteria for imminent risk. Um, and when I hear imminent risk, to me, it basically means that this is not something that I can handle outpatient. It's just not safe. So when I am faced with this scenario, my response would definitely be to be calm. I'd definitely be direct, but also very supportive. Um, I would make sure that I am hearing him correctly. So I would say something along the lines of, based on what you're telling me, I'm very concerned about your safety. I cannot let you leave today without ensuring that you're safe. I think this is a good starting point in discussing um, an elevation in care, because I need to make sure that what he's telling me is exactly how he actually feels. So I would then proceed by saying I would strongly recommend voluntary psychiatric hospitalization for stabilization, um, because I then know that he will be safe and he can have help that he needs, have the help that he needs. If he were to refuse that, because he endorsed having a plan and means and intent, I would definitely attempt to initiate an emergency involuntary hold according to state mental health laws. And I would also arrange to have his firearm secured and begin stabilization treatment once he is in the hospital. So coordinating with the social workers um, and the team on how to get the process going, in coordinating admission, emergency hold, so calling crisis. Um, Here in Wisconsin would be calling crisis and trying to get the patient either chaptered um, and placed inpatient, and then trying to figure out, how to secure those firearms. Once he's inpatient, then we can focus on interventions to stabilize his mood and reassess his medications. But due to the imminent risk at this time, that gets put off until the patient is safe. The second patient is a 19-year-old postpartum woman. She's 2 months after delivery, presenting with rapid speech, loose associations, and fixed delusions involving her baby. She reports believing that the infant is an alien and has plans to take the baby to the desert. Her husband confirms that these are new and escalating symptoms. So for my crisis plan for this patient, my immediate priority would be to protect the infant. I would not allow her to leave the office with the baby, and I would explain to her, your mind is moving very fast right now, and the thoughts that you're having are making it unsafe for you to care for the baby. Um, Also mentioning that maybe her husband is concerned as well. And I would furthermore add that this is a medical condition that is treatable, and that the safest way to treat this would be for you to get hospital or inpatient care. So I would start the process, again, notifying the appropriate staff, such as social workers, and trying to get the patient to sign involuntarily. And if that is not possible, then to attempt to chapter the patient. And in Wisconsin, it would be a Chapter 51. Additionally, I would also contact CPS, Child Protective Services, to ensure that there is temporary safe custody of the child. We don't know much about the family dynamics, so making sure that there are people there to assess where the baby needs to go and make sure the baby stays safe. Medications, initiations, and such as antipsychotics, that would take place once we know that the patient and the baby are both safe. In summary, Both of these cases require stepping beyond routine outpatient care. In both of these cases, I would not try to um, manage these patients outpatient. I wouldn't initiate any medications. I wouldn't do any of that. I would definitely try to get the patient to the emergency room to be evaluated and hopefully sign in voluntarily. But if that is not the case or the patient is unable to, um, being able to initiate um, the crisis team and being able to get the patient um, either chaptered or put on a hold. Patient 1 definitely required hospitalization to prevent suicide, versus patient 2 was more to keep herself and the baby safe. And that's obviously something that would not be able to be managed um, outpatient either. Um, this one we might involve other people more than just social workers or the crisis team. We might also involve CPS just because we don't know the rest of the dynamics of the family, and we want to make sure that what we're doing is we're keeping everybody safe. Crisis management, I think, for both of these scenarios is that we need to be clear, we need to be calm, direct, supportive. You know, this could be scary for patient 2 who we're telling we have to take away the child, when she already has these thoughts in her head and has this plan to do all these other things like go to the desert. They're not able to make clear decisions and they might not be hearing what you're saying. So making sure that you are clear, you are direct, but also understand that you have to be supportive are all like key components to making sure that um, families feel guided and the patient feels like they're understanding the transitions and why, because safety is always going to take precedence over ongoing treatment. And both of these cases highlight um, imminent risk, which is something that we need to take very seriously. And so both of these patients require a higher level of care that should not be managed on an outpatient basis. And here are my references. Thank you so much for listening.